Hello, my name is Dr. Harley Schultz. I practiced internal medicine for many years and am now the president of Associated Patient Advocates. Our contact information is on the slide. As advocates, we partner with other reputable organizations to help patients get their best care, and we are proud today to partner with our colleagues at the Second Opinion, who will be talking about their organization, which provides free services to patients with cancer. Now, who are Associated Patient Advocates? We are dedicated to helping patients and their families get the best possible health care. We know that things are stressful and confusing. When you have an illness, you may not be able to focus, and we are here to help. We have a multidisciplinary team of medical professionals with a wide range of experience and expertise. We are an internal medicine physician with many years of experience. We have on our team a licensed clinical social worker who can deal with the social and mental health aspects of issues. We have 2 registered nurses, one of whom is a certified diabetes care and education specialist as well. Our nurses have experience in medical surgical nursing, as well as an operating room, as well as home care, rehabilitation facilities, and acute care hospitals. One of our members is a healthcare facilities administrator who has worked for many years in the healthcare field and is very familiar with what happens in nursing homes, rehabilitation facilities, assisted living facilities, and really knows the resources. And one of us is a certified biller and coder who can help you deal with those rather overwhelming medical bills. When might you consider engaging your own patient advocate? Perhaps you had trouble getting all your questions answered at a doctor's visit, or you were so overwhelmed you couldn't concentrate and remember even what happened. Some people have told us that they left their doctor's office or clinic thinking that they wished they were a dog because they feel like their veterinarian is more caring and compassionate than their doctor or clinic. Perhaps you have trouble understanding the recommended care plan or the reasons for the care plan. And very often, people are worried about their insurance coverage, prior authorizations, what it will cost. And it has been shown that many Americans forego needed care because they are afraid that they cannot afford it. Lately, a lot of people go on the internet and they get even more confused. We are here to tell you that you should not get your advice about your health and well-being from anybody other than a qualified professional, which is why we have partnered with the Second Opinion today, because we know them to be qualified and professional. In addition, sometimes you or a loved one may need to leave their home because you are no longer able to function well at home and you need to go into a facility. Conversely, you may need to transition from a hospital to a care facility or to home, which can be a very, very difficult and stressful. How do we work? We work only for the patient and their family to represent their best interests. We do not work for any third parties, including your insurance company, the hospital, or anybody else. While we will not make your decisions, we will try to provide you with reasonable alternatives so you can make your own decisions, and then we will support you. With your consent, we will intervene with the healthcare system on your behalf. And perhaps the most important of all, you do not have to make this journey alone. We will be there for you to help you and stand by you as you take on the challenge of dealing with your health and well-being issues. As a public service, we have been presenting a monthly series of webinars. This is one of them. We expect to be presenting several webinars on the economics of healthcare. In other words, follow the money. On our webpage, you may see our events that are upcoming, which we will post as they are scheduled. You can also see our past presentations on our website blog page. The URL is below. You can also go to YouTube and look for our YouTube channel. Once again, we are AssociatedPatientAdvocates.org. As I said, we work only with reputable organizations, and I was delighted to know that my long-term colleague and friend, Dr. Aurora, has been working with the Second Opinion in San Francisco. Take a moment to look at their contact information. I have known Dr. Aurora for many years and have not only referred to many patients, but also my own family members. I know that Dr. Aurora is trustworthy, and I have great faith in the Second Opinion and what they do. Therefore, it is my privilege today to introduce Dr. Aurora and his colleague, Dr. Kleckner, who will discuss in some detail how the Second Opinion works, what they do, and how you can get in touch with them. Thank you.
Okay, hi. It's a pleasure to be here today. Harley and I have known each other for, I guess, close to 30 plus years, more so in the last 20 years, and increasingly over the last 4 or 5 years. So I understand fully what Dr. Schultz has been talking about, his work of being a patient advocate, and why he felt it was necessary to have an organization like what he has created now to guide patients so that they can get the best optimal care. It has been my goal also, just like his, to be patient advocate in the management of cancer patients, which have so many different facets of management, not just chemotherapy, but actually more than that, appropriate management in a holistic fashion. Towards that end, when I retired, or as I was getting close to the retirement, I decided to look around, and looking for other opportunities where I could continue what I did for 40 years in practice of medical oncology. I was lucky, and I was blessed in that sense to run across Dr. Howard Kleckner in a seminar, in a medical meeting. And he and I had known each other not in person, but shared patients because he used to work at the oncology division in Kaiser in Hayward campus. And I came to know of him by sharing patients, and I knew he's a superb oncologist, and I trusted him. And similarly, I came to know about how they ran their tumor boards, etc., through another colleague of mine, Dr. Ranu Ball, who used to be part of the tumor boards at the Kaiser facility. So when I talked to him about the fact that what he's doing and so on, he introduced me to the Second Opinion. I didn't even know an organization like this existed in the East Bay, in the city, and he invited me to participate and observe what they do, and I was absolutely flabbergasted that they spend so much time and gave solid information, and their goal has been to communicate the recommendations in a down-to-earth, easy-to-understand manner. But I was quite surprised that we used to have patients I saw coming from after having gone to Stanford or UCSF or another opinion, where they couldn't understand what was explained to them, or they were kind of stunned, so to speak, as to what the options were, so many, without any particular guidance at which might be the best option for them. So that's how I got introduced to Second Opinion, and I'll introduce Dr. Howard Kleckner now, if he comes online here, to talk a little bit about the history of Second Opinion and his experience there as the medical director.
Thank you,
Howard?
Robbie. Can people see me?
Yep.
All right, so I'm Howard Kleckner. I'm the medical director of the Second Opinion, and as Robbie told you, I was at Kaiser Hayward for over 30 years as a medical oncologist, starting at the time when there weren't very many medical oncologists, particularly on the East Bay. So things have changed. And when I retired, as Robbie pointed out as well, I was like Robbie, one of those doctors who actually liked what we did and wanted to continue in some way to be able to help people, because we felt we still had our skills. And I came across the Second Opinion in the same way, and I've been there for over 10 years, initially just being a volunteer, but then became medical director when the former one retired. Now, it's going to be hard to believe this, but the Second Opinion has been around for 51 years. And it's one of those things when I tell people about our organization, they say, gee, that sounds like a great organization, but I never heard of it. And this includes many medical people. So I feel really good that we have this chance to tell you a little bit about ourselves, and perhaps you can tell other people as well. Well, 50 years ago in the Bay Area, there were probably a handful of specialists that dealt with cancer. And doctors were sort of wringing their hands of what to do. They didn't have medical specialists in cancer, either surgeons or medical oncologists, which in those days probably didn't even exist. The Association of Medical Oncologists, the ASCO organization, was probably not even 50 some years old. But in any case, two doctors, one from UCSF, who was a surgeon, and then the chief of medicine UCSF, and then a surgeon from Stanford, decided to start this free service as a community service for doctors in the community who had cancer patients and wanted to be able to present the cases to doctors who are experts in the area. So they got a grant of, well, I think over $1 million to start this thing. And they started with an office in San Francisco. And it was just they two, and then maybe a couple other people that they knew at the university who volunteered to run what are equivalent to what some of you may be familiar with as tumor boards. And doctors would come with their cases, present the case to this august group, and present questions that they needed to have answered about, does this patient need surgery, or what should I do? And that was the nature of it. And then after about probably 10 years or so, more and more doctors went into the specialty of oncology, both medical oncology, radiation oncology, surgical oncology, ultimately gynecologic oncology. And now, if you look even in the Bay Area, most of the oncologists have taken to treat selected diseases. So there are medical oncologists that treat only breast cancer, or gynecologic oncologists that treat ovarian and endometrial cancer. But in those days, are we okay? Can you hear me?
Yeah.
Perfect.
Okay, sorry. So for a period of time, as different hospitals developed their own doctors, the need for the organization sort of waned. and it had to change in nature. So previously, as I pointed out, the doctors used to bring their cases there. They would present the case and get an opinion from the doctors who were on this tumor board. But we changed it. It changed maybe 20, 30 years ago. Make it available to patients themselves so that the patient could just call up and ask to be seen for a second opinion. And it was never of any cost to the patient. All the doctors were volunteer, and they remain volunteers. We don't bill insurance companies or Medicare. We do have to raise money, and we do that through different events that we have through the year from selected donors, and we have some very generous donors, grants, and foundations. And we have an office in San Francisco. But with COVID, we've not been able to use that office. So all our tumor board panels take place on Zoom. Now these panels run once a week, and we usually will we handle 3 patients. What happens is a patient will come to us in different ways, but they can self-refer, so they can get it through, they can email us, they can call us, they can get us through the internet. Many of them are told about us through their doctors, social workers, support groups that they are part of, and have this desire for a second opinion. Now, we see people, whether they have insurance or whether they don't have insurance, whether they have Medi-Cal or not, but and we see people, as Ravi pointed out, that have already been seen at UCSF or Stanford and still don't quite understand what to do. So we get all the information 2 or 3 weeks in advance, and it's given to one of our panel chairs, the person who runs this tumor board. He makes a summary of the case. Those summaries go out to the doctors who are going to be on the panel 1 week before the panel. So before this tumor panel meets, the doctors are familiar with the cases. In addition, we get all the imaging, all the films, that is to say, the scans or x-rays or whatever has been done, MRIs. And we also get the slides, the pathology slides to review. And they all get gone over before the tumor board meets. So by the time we meet, all the doctors know about the cases. They know about the radiologist has seen the films, and the pathologist has seen the slides. And then we'll meet for about an hour before the patients come. It's usually on Friday at about 12, but we meet at about 11. And we go over the 3 cases in advance of meeting with the patients, so that we're all on the same page. It doesn't look good to be arguing at the session. So we try to get a consensus about things. We ask all the patients to send us 4 questions in advance of the tumor panel. So the doctors also sort of had an idea of what the patients want to know, and they can address these questions. When we meet, the patients come, they're on one of these little screens like you, and they bring their family or a friend, or they don't bring anyone, but this is not something that's directed to issues that the doctor has, but they're issues that the patient has. Now, they may be the same questions that the doctor might ask, do I really have cancer? Or, how are you sure that the pathology is correct? Can I have it checked again? Or what sort of treatment should I have? Doctor said I should take chemotherapy. Is that really necessary? And I heard bad things about chemotherapy. And radiation, I'm scared of radiation. And what will it do? And what are the long-term side effects of all these treatments? And if I take the treatments, will it really help me? Will it make me feel better? Will it make me live longer? So these are all the issues that people have, regardless of whether they trust their doctors or they don't. And so we spend about probably 30 to 40 minutes with each patient. So we start at about 12 or so and finish about 2:30. At the end of the session, a summary letter is written by the panel chair, the fellow who runs it. We have about 70 volunteer doctors, and they're in different fields. So we have pathologists, radiologists, medical oncologists, radiation oncologists, radiologists. And then we have a GYN oncology. We have breast surgeons. But we don't have the whole span of cancers. So if we get a patient who obviously has got something exotic that we don't feel comfortable in dealing with, we'll help the patient give them names of people that probably would be appropriate for them and wouldn't handle the case ourselves. Now, after the session is over, the panel chair writes a letter summarizing all the discussion we had about the case, just as any other consult letter a doctor might write. And it's sent to the doctor and it's sent to the patient. And the patients are incredibly grateful for the opportunity to sit. I mean, can you imagine, this is a service you can't pay for. In other words, if you go to get a second opinion, you're sitting with another doctor who sometimes you don't even know. But here we're sitting around a table, well, in this case, Zoom, and there are 3 or 4 doctors, all of whom have reviewed your case, looked at your films, seen your pathology slides, and you have access directly with them. And you can ask your questions directly to them. So it's a very unique type of experience for the patients. It's also a very satisfying experience for the doctors because it draws the kind of doctor who enjoyed what they did and welcomed the opportunity to continue to benefit other people. So I think I'll just stop there for right now and open it up to some comments or questions. And if we have time, I can sort of give you some examples of the kind of thing that we deal with. So I'll stop and see if anyone has any questions or comments. If you don't, it's fine too.
Thank you, Howard, very much for that overview. And I know that I recently referred you somebody, and I am delighted to have known that such a resource existed. Couple of questions. One is, does the client have to live in California?
Well, it turns out that we do see patients from all over California, mostly, of course, from the Bay Area. But now with Zoom, we have access to people all over the state. And in fact, we have one doctor who Zooms in from, that helps us as a radiologist who lives in Santa Barbara, and another one that lives up, near Tahoe. So we have access to doctors we normally wouldn't have. But there is a law about practicing medicine outside of a state if you don't have a license in that state. So even though we would like to be able to do that, number one, we don't have the resources, to be able. These doctors are all volunteers, so we don't probably, we don't want to be inundated. But we can't practice across state lines because this is considered practicing medicine. You can do it if, for example, Harvey called me up and presented a case to me, and Harvey lived in New York and I live in California, and I tell him my opinion. Doctor to doctor talk is okay, but doctor to patient talk is considered practicing medicine. So we don't see patients outside of California.
Okay. What would happen if somehow or other the word got out, you were so popular and you were deluged with 100 cases a week, and obviously you could not take them all?
Well, it turns out that happened once. They came from one of these stations, like Channel 4 or Channel 7, because they had heard about us, and they came with their cameras and interviewed us and stayed for part of a session. They can't sit in on the tumor board because it's privileged, information, but they did come and talk to patients before they got met and after they were seen. And then that week we got about 50 phone calls of people that wanted to get seen. And so it's one of the problems with being, the thing is that it'd be different if we were a moneymaker, because the more we see, the more we would make. But we don't have that kind of, we don't have enough doctors, we don't have the resources to do all that. So it is a problem. But it turns out that we managed to fill up the slots we have, and we're able to see patients probably within 2 to 3 weeks. But there are some patients that need to be seen sooner, or else don't want to go onto a Zoom. So we will handle those people one-on-one with a doctor. So for example, if you have a patient who has breast cancer and is trying to decide about surgery and doesn't really understand surgery or what they should do, we would, and it has to make a decision next week, and we don't have a panel opening for 3 weeks. We'll ask one of our breast surgeons, would you be willing to review the chart and talk with this person? And so they call the person up and they talk to them. And actually the reviews we get from the phone calls even surpass the reviews we get from people who have come to our panels. Because the idea that you can have this one-on-one experience is very powerful to people.
Great. What happens if you have, say, referrals from some cases that, say the patient wants a second opinion, but you look at it and the situation is so cut and dried and standard that, you really don't think they need a second opinion, that actually what was recommended is perfectly adequate, and 99.9% of the time, there wouldn't be any question. Do you take that case, or do you just advise?
It's an interesting question. I would say that when people come to see us, everything they've been told 90 to 95% of the time is correct. So we're not in the business to look for mistakes. We're more in the business of trying to help both the patient understand their disease and help the doctor take care of the patient. And when I was in practice, people would say, well, you think I should get a second opinion? And I would tell them, look, this is your disease, not my disease. I'm not invested in my opinion. I'm trying to do what's right for you. And if you feel you need more information, you want confirmation, or if you don't like me, then I think you should go ahead and get a second opinion. They get a second opinion. They come back to me. They were told the same thing I told them, and now I'm a hero. I'm a good guy because everything I did right. They come back to me and said, this other doctor told me I should take this stuff. And, I said, look, I have no problem with that. If this seems like a reasonable thing to do, then we'll do it. So I think second opinions for some people, not all people, because some people get paralyzed with too much information. It only makes it more difficult for them. So, and in addition, they trust their doctor. They don't need to start looking for other people. But I would say, to answer your question, I think 90% of the time, everything that the patient's been told is correct. And they're coming for a better understanding, for confirmation, and to be able to ask questions that they've never had a chance to ask. And we're an added advantage, because the first time you go see the doctor and they say you have cancer, this is what we need to do, you're so overwhelmed, you probably don't remember anything else that's been told. And then after a while, it starts to sink in, and then you realize your surgical date is in a few weeks, and you still don't understand what's going on. So when we see them, we can explain in more detail exactly what they have and why they need what needs to be done, even though we're not telling them they shouldn't do it or they should do something differently. Mm-hmm. Now, on occasion, we do find problems, but for example, a patient might have a misdiagnosis. We had one patient that had, I don't remember, was said to have had non-Hodgkin's lymphoma and turned out to have Hodgkin's lymphoma. And the pathologist helped us with that. another patient who was told that his scans were negative, and they did have something on the scan. But that's the minority of patients. I mean, doctors, and I can tell you because I review a lot of the charts, the doctors in the Bay Area are excellent, especially the oncologists in the Bay Area. They're well-trained and they're very knowledgeable. And most of what they tell people is exactly right. So it's a long-winded way of answering.
Thank you. So let me put this out to you.
I think, Harley,
Go
just to
on.
give you that, it is not necessarily that we do is to tell them something brand new,
Mhm.
totally unexpected. What we do is basically what we do in our practice when we get second opinion requests in private practice.
Mhm.
Also, basically, it is either they didn't spend enough time, they didn't communicate correctly, something happened that they didn't connect with the other person, and they want reassurance. And they come sometimes saying that they think they're getting the right treatment. They just want to be reassured
Right.
in an expanded way, spend some time, get to know them, and explain to them. That is what we do. But as Howard pointed out, there have been cases, including in the last 2.5 years, where I felt that their pathology slides need to be re-reviewed.
Mhm.
So, but there is a way of approaching that and a way of conveying that to the reading pathologist also. So I think what we do and what I think we specialize in is in communicating our thoughts clearly, precisely, well understood, without being critical of what we see.
Thank you.
I might add something to that because I agree with Robbie. You have to remember, we see the patient and the patient goes back to their doctor. And we have to be very discreet in terms of not undermining the relationship between the patient and their doctor. So when we explain things to patients, we're very careful to make sure we're not undermining the relationship that they have, because they go back to that doctor, and the doctor is quite willing to go along. It's rare that we've ever had a patient say, my doctor got upset because I went to get a second opinion, and he doesn't want to take care of me anymore. That just doesn't happen.
It doesn't happen. No.
It does not happen. Because what I was going to ask you is, what would you say to a patient where they went and talked to their doctor and said, gee, would you object to my getting another opinion? And the doctor objects. The doctor blows them off or makes them feel like they are not trusting the doctor, and they get the feeling that the doctor's not happy about that question.
Well, first of all, in the last 3 years, I've been with the second opinion. We haven't had that very, very specific question you're asking, that as an issue.
Mm-hmm.
There have been many issues, many cases where, quite a few cases, I would say, where they felt that they just were not explained well, okay? Not that they were completely denied. And frankly, if anybody did show up in that setting and we accepted the patient, we would, at least I would, pick up the phone and call and be very open to the doctor and say, hey, he wanted a second opinion and he came to us and this is what we are saying, and we actually agree with what you're doing. So I think it kind of diffuses the issue, the way we approach this issue at the time when we pick up the phone and call in that kind of situation. I mean, that's exactly the way I would have done in private practice. I mean, people have come to me in that setting.
Right. So in that case, the
here.
patient can self-refer. They don't need a referral.
That's right.
Absolutely.
And I'll say something else. If a doctor is that, reacts that they're insulted that you went to get a second opinion, it's probably not a doctor that you probably want to be with. I think somebody who's threatened in that way, it's not a good sign.
No. Well, I didn't want to put words in your mouth, but I was kind of angling for that. If you must.
No, but the fact of the matter is that patients are not dumb. They understand this. And even if we are trying to say that we will work with your doctor, they'll understand, they'll figure it out that this is something which did not appeal to us as doctors. They'll get a sense of that. And if they get a sense of that, and if they ask me specifically, then I will give them an answer, which I would have given in my private practice also. Yes, you can go and see so-and-so, which I think is the best person for you. But that hasn't happened in the last 3 years. How often has that happened to you, Howard?
No, I
That
think
somebody
people,
came,
no, I don't think so.
yeah.
You know, being an oncologist is a weighty thing. We don't always understand as doctors the power that we have. And when a patient wants a second opinion, you have to keep in mind, this patient has cancer, they're afraid they're going to die. And if they want to get a second opinion, go ahead and get it, because you have to have peace of mind with what you're going to, look, these people are going to end up with chemotherapy, they surgery, radiation. I can't blame anyone for not wanting to get a second opinion, for getting a second opinion.
We have had occasion, at least I had an occasion where I felt the patient would benefit from a clinical trial setting, for example. And I've said that to the patient that I think, and I researched it and found out which clinical trial they may be eligible for because they've been told they don't have a diagnosis which doesn't have a very good treatment option. If we get that kind of opening, I do talk about that part of it. And as a matter of fact, I have called up the doctor prior to the patient coming in and say, hey, this is what I'm going to say. Is there an issue you want to discuss with me? Because, this is what I think is the best thing for you. And more often than not, they agree.
Thank you. Okay.
Dr.
I
Rohra?
was going to turn this over to Susan. Thank you very much for jumping in, because I would also like you to talk a little bit, Susan, about the stress and the mental issues in patients who have a diagnosis of cancer.
Sure, thank you. So Dr. Rohra knows me very well. And I want to say to you, Dr. Rohra, and specifically that, as you know, half of the issue is that the person wants to hear something different. They want another doctor to tell them they don't have this, it's not so terrible, you could do this, you could do something differently. Or there's a family member who feels that that's what they want to hear. And also, they don't hear half of what the doctor says, as because we worked on so many cases together. And also I want to say that not every doctor, as wonderful as a doctor may be clinically, takes the time to go over all the details with the person. So many times when you and I were in Castro Valley together and someone would come into the conference room to see me, they would bring up so many issues at the same time. I would tell them it was analogous to a plate of spaghetti. There were so many noodles on the plate. Who the heck would know what they were dealing with? I'm going to take like 4 noodles off the plate and try to deal with that. So the patients and the families need a lot of attention clinically to understand what's going on, to process the fact that this is, they'll come in and say, how would I have this diagnosis? No one in the family has ever had this diagnosis. I eat properly. Why do I have cancer? Well, my friends eat all kinds of things they shouldn't eat. And I'm on a very careful diet and I get regular exercise and I go to the gym and why. And I tell them, there's a book that maybe we'll have you read called Why Do Bad Things Happen to Good People by Rabbi Kushner, So no one knows. You're asking a question that no rabbi, no priest, no one could answer that question. No one knows why these things happen. We have to just try to look at all the facts and come up with the best plan and the best family plan. And one thing that I do, and I hope to do a lot of with Harley in our organization, is to really help people sit down and understand this is what's going on. Of course you're confused. Of course you're overwhelmed. We know you're overwhelmed. I'm the first one to say I would be overwhelmed too. I think you're doing very well considering everything you're dealing with, but we have to sort this out. There are many, many issues here. You know, we have the financial issue, we have the socioeconomic issue, we have the different people in the family issue, you know, not just the doctor issue. And one thing that you said, Dr. Rohr, that I thought was so right on is that, and Dr. Kleckner, I believe it is, said the same thing. Yes, am I pronouncing your name correctly? I hope. Is that people can't hear what it is that you're saying half the time. They don't even hear what the doctor said, because then the doctor will refer them to me for psychological, and they'll tell me, I don't have any idea what the doctor wants from me. I don't know what to do. Someone just told me today, I'm so afraid of chemotherapy. I'm afraid of losing my hair. My hair is my glory. She had hair halfway down her back. Actually, when the hair fell out after her first treatment, the doctor thought it would be her second treatment. She was really kind of relieved. She says, you know what, this hair, Susan, isn't that really good anymore. This is kind of not good hair. I think I look kind of cute in a pixie cut, you know, because if the hair falls out, I think the treatment may be working. So maybe the fact that the hair is falling out is a good sign. But these are all the kinds of things that I process with patients, both individually and in groups. Now, as Dr. Aurora knows, I'm not doing groups right now because of COVID. They're the practices are hesitant about the groups, and some of the people don't want to have groups on Zoom. They feel are not as personal. What can I do? Right? I'm just, I can just do the best. But psychologically, both working with pediatric as well as adult oncology. I did that when I was in Boston. That's where I was trained at teaching hospitals in Boston. Very, very tricky. And I think a lot of times the hardest person for you as doctors to deal with is a family member. A lot of times the patient is in better shape. I teach them about they're a person first. I draw it out. I make a big P and a little C, and meaning you're a person. You want to be a person first who happens to have cancer, not a big C. So the cancer is your whole life, and then you're a person next to that. So the cancer is one part of your life. How are we going to integrate everything? So that's where I'm coming from, and that's why I am enjoying so much working with Harley. And because I can do this, and as you know, Dr. Aurora, you know how I enjoyed working with you and how we worked side by side with the families. So some of the families, would say, well, I know Dr. Aurora is very smart and he's, taking time and he's talking to me and this and that, but I don't understand what he's saying. And maybe I don't have this. Maybe it's an error, maybe like you were saying, So there are a lot of different things to sort. I hope that helps, Harley.
Say one thing that I tell patients to ask their doctor if they go to a university is be sure when you're there and they offer you treatment, ask two questions. Number one, will it make me feel better or will it prolong my life? And if they can't answer that question, then it's clear it's probably not going to be a treatment that's going to benefit you.
Yeah, and I think that they should deal with that too. I wanted to ask you also
we have doctors who are both in practice and volunteer, and people who are retired. The majority of the doctors are retired. They're usually recently retired, but we feel like when the patient comes to us, they're really coming to get. To get some expertise in this area. So we usually don't have, for example, primary care doctors participate, although we wouldn't necessarily have any objection. But in general, it's usually a person who's trained in a specific area. So if we'll have 3 patients on a Friday, one of them has prostate cancer, we'll have a urologist on the panel. One of them has breast cancer. We might have a surgical oncologist on the panel, but we wouldn't have a primary doctor.
Yeah, I understand.
Dr. Susan Heckman, who's on this call, she's one of our volunteers. So hello there, Susan.
Hi, how are you?
Hi. Hi, Susan.
I was going to say a couple of different things. During the beginning of COVID, I ended up doing a couple of the consults on the phone. And I'm both of those people. Well, the first one, she had seen her, this was breast, and she had seen her oncologist and was told what her options were, but she had gone by herself. And so when we ended up on the phone together, we weren't doing Zoom. Part of the second opinion was to have her husband there so he could hear what we were talking about. Then they went through that, and then we did another call after they kind of got used to the information. And then we did a third call because it came up whether to do reconstruction or not. So we got to know each other quite well. And the same thing had happened.
Many people feel so alone. It seems to me everyone needs an advocate. Everyone needs someone on their team, just to.
You know, Susan, we get many patients from San Francisco General, and they have cancer navigators there. And they often come with their cancer navigator who actually has gotten them the appointment. Because particularly people from San Francisco General don't understand anything about how you get a second opinion, why you get a second opinion. And we have some of those people are scared of treatment and they don't want anything. So the navigator brings them to us to try to convince them as to why they need treatment. So
Thank you.
I'm a patient. I've had ovarian cancer now for 9 years and I'm in my 4th round of treatment. And I just, first of all, just want to say thank you for what you're all doing. I've heard about you from my Chinese medicine doctor. I've referred patients to you, and I'm kind of sitting here a little bit overwhelmed with gratitude for what you're all doing, both on the patient advocate side and the second opinion. I mean, it's just huge. And most of my questions that I've been writing down, you've subsequently answered. One of the questions that I had was sort of where in the life cycle of a patient do people tend to come to you? I'm wondering whether it tends to be people who, when they first get a diagnosis, or whether you also see patients who are getting to sort of end of treatment. I mean, I'm personally in my 4th round of care here, so it's been a long time. And I've been wondering at what point would I perhaps call you up? But I'm wondering also whether it's generally at what time do you find people coming to you? I realize that might be a sort of how long is a piece of string kind of question, but and I was also interested to hear that you see a lot of patients from SF General, and I'm wondering how diverse the community is. Sometimes we do get to the stage where we don't need more treatment. We need palliative care, or we need to deal with the side effects more than the the curing of the disease. That it's the treatment that's killing us.
Oh, you're right. I mean, certainly at the point where the treatment is worse than the disease, it's clearly time to stop. And some people are willing to accept that, and some are not. So, but in terms of the kind of patients we see, I would say we see the whole range. I mean, we'll see a woman who had a breast biopsy and is told, you could have a lumpectomy or a mastectomy, or a man who has prostate cancer that's been biopsied and he's seen several doctors. One doctor tells him you need surgery. One doctor tells him he needs radiation. One doctor tells him you can just watch it. So they're struggling with, at the very early stages, of what to do. And then, like you point out, there are people who have been through treatment who, there's a kind of patient who accepts his status and is just looking for confirmation. And there's that kind of patient who is still struggling with acceptance and looking for perhaps someone that might be able to offer something in addition. So I would say we see the whole range of patients. In terms of San Francisco General, we also provide interpreters. So we get Chinese patients and we get Spanish-speaking patients, particularly from San Francisco General, and we will provide interpreters for them. We actually, there's a group of students, this is amazing, at UC Berkeley, who volunteered to do medical interpretation. So these are undergraduates who come with the patient and will, speak Chinese, and they're trained as medical interpreters. The problem with bringing a family member is sometimes in certain cultures, you're never sure if the family member is telling the patient exactly what you said. Whereas when you have an interpreter, you're more reassured that that's going to happen.
Anybody else?
Probably the easiest way is just to go to our website, the Second Opinion, that's one word, .org. And on it, that's our webpage. It'll have all the information you need, how to get a hold of us. If you want to fill out forms right there, asking you questions so we can screen your situation. It'll also give you the phone number and people that to contact. We always have, you won't be put on hold. I mean, there's somebody that will answer the phone, but you don't have to do it that way. You can do it online.
Thank you.
Great.
And
Yeah, thank you.
so our website is www.associatedpatientadvocates.org. And our phone number goes by the catchy 510-531-HELP.